Come on in, everyone. We might get started. Thanks, guys. Welcome to the next seminar in the Research Skills Seminar Series. My name is Sue Scull and I'm responsible for the program throughout the year. And I know some of you will have been to one of these before, but if you haven't, the idea is that throughout the year we have over 20 seminars, and in each one of those we try and touch on a different aspect of the research process. These go for just 1 hour and we absolutely pack it in, and we try and provide you with an overview. So every topic in itself is enormous, so we do the best we can with the hour, and then we put a lot of effort into our handout. So you'll find the PowerPoint slides, but at the back you'll find a lot of extra information, resources, other training opportunities where we know about them, and hopefully some practical information to help you do your research more easily. We do record these and they go up onto our website and they're there all year. So if you know someone who's missed this that really wanted to attend, then please have a look there, and you can find all our other seminars there as well throughout the year. And because we record them, we ask you to hold your questions to the end, and even people who are off-site, you can ask your questions also at the end. We'll have someone monitoring the chat. So let's get started, because this is a biggie. Well, they all are. This is a really important topic, and I think data collection and management is often an area where people don't really know where to get help or how to get started. So I'm hoping by the end of this you'll have a few practical strategies about it, and there's lots more information in your handout. So I'm going to talk about why good data management is so important, and then a little about your responsibilities as a researcher handling data, things like collection and storing and archiving, and then actually the practicalities of strategies for data management. We'll then talk about some of the basics to think about when you're setting up a database, and importantly how you go about minimising data errors, and then a whole stack of resources will be covered as well. All right, so obviously when we conduct research, we're trying to impact on policy and practice, and we can't do that unless we've got super high quality data that's the most complete and accurate as possible. And without that, we may end up with data that are so poor quality, or you might lose them, or something else terrible might happen along the way, that we can't do that. And that has an impact on you as a researcher, your institution, and of course if you're dealing with participants, you've also wasted their time. So it's really important to get across what is expected, and really important to plan what you're going to do around data management before you start a project. And every researcher will tell you that the more effort you put in at the front end of a project, thinking about data management issues, the more efficient and successful your project's going to be. So everyone will say it's highly worth it, and you'll have heaps of benefits and efficiencies come out of it. So as I said, it's all about high quality data, so it's got to be accurate and all of these other things: complete, good response rates, retrievable, secure, available and identifiable. And it's really important to meet your legal and institutional obligations. We're going to talk a bit about that. And obviously we're looking to prevent the big obvious disasters like leaving the USB stick with identifiable patient information on the bus. You can actually be prosecuted in law for confidentiality breaches as a researcher, so we really got to think about dotting our I's and crossing our T's. Where you do have good data management systems in place, it's just so much better for the running of the project, and all of us will be audited at some point, either internally or externally, about our data management practices. So it's so much easier if you know exactly where everything is, who's got access, what the security is, etc., etc. And then it will all run super smoothly. So what are your responsibilities? You need to know your institutional policy or codes around data management, and they all do vary a little bit from institution to institution. Some of the information is embedded in good clinical practice training, which I hope you will have heard of. GCP training outlines the standards for conducting research, and part of that is data management. And in some countries it's mandated by law, for example in the UK, that you must update your GCP training every 2 years. So we don't yet have that here in Australia, but it's increasingly moving in that direction, that we must be up to date, and the onus is on us as researchers to be up to date with requirements. And if we aren't, then there can be quite significant consequences for all of us. So funding bodies can withdraw research, or you might jeopardise future research opportunities. As I said, there are legal implications, and we are able to be prosecuted for breaches of confidentiality. And then, of course, as I mentioned, reputation. And increasingly, I'm sure you will have all noticed that in order now to submit for funding or put in grant applications or ethics applications, and certainly many institutions and government bodies require that we have a data management plan as part of our submission. But the good news is that there's lots of support out there. So I'm going to talk about data managers, but also biostatisticians and IT people can also help. And as I said, do some GCP training. As a minimum, these guidelines and codes are things that Australian researchers should be across. And all of the links to all of these documents are in your handout. But we should know quite well the Australian Code for the Responsible Conduct of Research and the National Statement on Ethical Conduct of Research from the National Health and Medical Research Foundation. In WA, we don't have a specific Privacy Act, so we refer to the Commonwealth Privacy Act, and we have a little bit embedded in the WA Freedom of Information Act. And more recently, NHMRC have brought out the competencies for Australian academic clinical trials if you're specifically working with clinical trials. But all of these are living documents, they're regularly updated, and they're quite big and there's a lot to read. So it's great if at some point you can work your way through them and then just refer to the updates, which are usually encapsulated on the front pages of websites when they occur. So the bottom line is know which data management policy you should be referring to wherever it is that you work, and follow the relevant legislation. And in general, a data management policy will cover this sort of thing listed here on the slide. So ethical data collection and maintenance, so things like having informed consent and getting ethics approval at some level, which the NHMRC allows. It doesn't always necessarily mean an ethics committee, but you must have some level of approval. And then understand things like data ownership. So, for example, some people don't realise that if you work for an institution or a hospital or you're a student of a university, that if you've collected data and done a research project during that period, the data actually don't belong to you, they belong to your institution. And even when you leave, you may or may not be allowed to take a copy with you. So it's very important to ask about that stuff and to keep very careful records of the data that you create during your research projects, and make sure that wherever you work is aware of that. It's also important to keep something called a data dictionary for every project, which is where you list all the variables, what they do, what they're for. We'll talk about how you make one of those a bit later. And that you've got password protection requirements, backup plans for your data so they're not lost or destroyed, and understand all the retention and disposal period requirements for data, which are different from jurisdiction to jurisdiction. So I'll talk about WA a little bit later. All right, let's talk about some practical stuff. So obviously we want to collect high quality data, and we do that first of all by designing a really super duper data collection instrument, and we actually cover that in enormous detail in our survey design seminar, and I'm not going to go through all of that stuff. I'll just allude to some of the practicalities today. But if you want to know more about that, have a look at our survey design seminar or handout. They're always on our website. We need a data management plan. We need to have really good systems around file organisation and naming, and stuff called metadata. So we need data about the data, and have a whole list of that. I'll talk to that shortly. And then we need really good database design. So we're talking about entering data so that you minimise mistakes. We're talking about validating all the data once it's collected and then cleaning it before we analyse it. And we also need to have very good systems around security and backup. All right. So my biggest advice when you're undertaking a research project is have very clear objectives and then only collect data that you need to answer those objectives. Don't collect a whole stack of stuff that might be interesting and you might want to do something about, because the Ethics Committee has approved the project as per the objectives, and you shouldn't go fishing around and wasting time on lots of stuff you might never use, because it's a waste of your time and your staff's time and the participants' time. So get the shortest list of variables humanly possible when you're designing your survey instrument, because you'll get a much better response rate and better accuracy, and as I said, it'll be more efficient. You need to have a sampling strategy, so unless you're lucky enough to have all the resources in the world and include every person who's possibly eligible to answer your question, then you'll have to take a sample, and that needs to be a representative, hopefully random sample if you've got a listing. And then you need to work towards maximising your completion rate so that, again, it's representative, and have standard operating procedures for all your staff around data collection and real-time training and monitoring throughout the life of the project, because things can sometimes drift and you might not notice that one person's doing it differently to everyone else, or misinterpreting something, or missing boxes, or doing things out of order, or whatever. So all of that's important, and piloting is critical. So if you piloted every step of the data management process in advance, it would be a very worthwhile thing to do, because you'll pick up all those little mistakes that will be problematic once you start real data collection. All right, so data management plans, as I said, are increasingly required, and the scenario on the right there is actually quite common, where people finish projects and they go off and do something else, or change careers, or move overseas and leave their data behind, and it's never used again because nobody knows what the variables mean or what it's for. I did a PhD many, many years ago, and people still contact me as the custodian of the data, even though it's sitting somewhere else, to use it for other purposes. And that's brilliant if your data can be used by somebody else. But you need to have really good documentation around how the data were created and what they're for, what the variables mean, and so on. So have a data management plan. And it's not only useful for you, for example, as I said, for future people to use, but also as people come in and out of projects that are slightly longer term, people need replacing or retraining. It's all there for them and easy to use, and also for people coming in to audit your project. So particularly if you're doing a randomised control trial, and particularly if it's sponsored by private industry, they will come and audit your project. And I can remember the first clinical trial I was ever involved with in Melbourne 100 years ago. We were audited and we discovered a whole lot of hospital records were missing, and they were being taken home in someone's car to their house, so that's a big no-no. All right, so the sorts of things that would be in a data management plan, and this is by no means comprehensive, but the sorts of things that I've listed in these dot points here. And I've highlighted the fact that it's always better if wherever you work has an institution-wide approach to data management. It makes it so much easier because you can jump from project to project and know exactly what the folder structure looks like and where you can find things related to the data or the consent or ethics or whatever it might be. So generally there are all these things, a list of all the data that are going to be created, who's going to own it, who's responsible for it, the names, the folders, the version control, all the things around access and security and backup and disposal, and also things like sharing and reuse of data. So you might want to be able to collaborate with others now or in the future, or have data reused in the future, and therefore you need to plan for that in advance, because there might be different levels of consent required and you might need to come up with some sort of an agreement. Responsibilities, who's allowed to do what, is really important to document. And you also really need to think about a budget for all of the curation of the data over time. And I'll talk a little bit about all the nitty-gritty of what's required shortly, and then you'll understand why budgeting for it is important. Also things like who owns the intellectual property. All right, so good clinical practice training will cover good file organisation and naming, and as I said, if you've got an institution-wide approach, that's so much better. But it's all about easily being able to find things, and also this idea of version control is critical. So if you submit patient information and consent form A to the ethics committee and that's the version they approve, and then you trial it and find there's a problem with it and you need to make adjustments, you can't use that new adjusted form until that has been approved. And once version B has been approved, you need to get rid of all the A's and make sure everyone is using B. Otherwise, that's a breach. So you need to be very careful about how that's going to work. And the other critical thing is always having a master copy of your data, and no one should do anything to that. As soon as it's opened, it needs to be saved as something else, and that's usually done in a command file. I'll talk to that later. So always make a copy before you do anything, and then usually use dates so that it's easy to know what the last version is, and also an intuitive directory structure. So that's just a really super obvious one. So you've got your project name and then a subfolder for the data, and then within that subfolders for the master file, the analysis command files, backups and so on. All right, so as I said, metadata is the data about the data, or the information about the project data. And it documents everything you've done along the way and why. And it usually has also a simple overview of what the project's for, and then outlines all the different files and what they do. And in every single thing you do, you should date who's accessed, what time, and what they did and why. And have a data dictionary, which I'll describe soon. And then also have all the backup processes in there. So when it comes to confidentiality and security, as I said, every institution can vary slightly, and failure to maintain confidentiality can result in prosecution. So, of course, we'll want password protection of our data. So for the laptop or the PC, any hard copy data, if it's self-administered questionnaires, they need to be kept as the originals in a locked drawer in a locked room, because they are your original data that you will go back and refer to if you find errors or mistakes or illegible things. And you must have a unique identifier for every participant or case so that their identifiable data can be removed and things can be kept confidentially, like name, address, date of birth and hospital numbers, for example. Everyone here will know how easy it is from a hospital number to go and look up someone's name and address, so that is not suitable as a unique identifier. We also need to be super careful with transport of data. So sadly, our hospital biostatistician tells me around 80% of all the files sent to her via email contain identifiable patient data, and it should be 0. So we need to do much better about that. And we've all heard horrible stories about leaving the USB on the bus, as I said. And those sort of things hit the paper. And if that's your PhD and it's the only place you've got it, and it gets out into the public, that's a huge problem. And backup, the key thing is have a credible strategy and write it down and actually follow it. And ideally, you're backing up your data at the end of every single day, and you make that automatic if possible. So that's great if you work in a big institution, because if you're keeping it on your institution's drive, it will be backed up every day, and hopefully even in more than one place. If you don't have that luxury, then you need to think about keeping your data in more than one place some other way, and ideally it's not on a USB, it's on the cloud or on a web-based system, as well as on a hard drive. And we all know even then that if you've just got a hospital computer and the hospital network and the hospital burns down and it hasn't backed up for some reason, that's a real problem. We've all heard of people losing their entire PhD data in one fell swoop because a PC's hard drive has packed up. So stuff happens. Also, data repositories are increasingly used nationally and internationally, so you can store your data, usually at some kind of cost, but not always, in a safe place. And think about file format planning. And it sounds silly, but we know that all data storage mechanisms can fail, like PCs, laptops, And also they become obsolete, which is the really important one. So I'm old enough to have started with floppy disks, and then we've kind of moved on to bigger and better things, and now we have web-based things. But we've all had experiences where we've tried to open an old file and it doesn't open anymore. So if you have to store some of your data for research, which you do forever, which is different in WA, then you need to have some system in place where at least every 5 years you have a look at where you've stored your data and the format in which it's stored is going to be obsolete, say, in the next 5 years, and do you need to upgrade it? So in the old days, it was getting things onto microfiche from paper, and then from microfiche onto floppy disks, and then floppy disks onto something else. But it will continue to happen, so we need to be across that. And again, as I said, sharing data and reusing data needs to be planned from the start, because at the start you might wish to have multiple levels of consent if it involves people, and say, are you happy for your data to be used for this project, for future related projects, and as yet unknown future projects, for example. And the sharing with other institutions needs to be nutted out at the start and agreements put in place. And there are places on the web like Creative Commons where they can give you templates for data agreements. That can be very helpful. And then you also need to think about the different sort of storage options. All right, this is really dry stuff but very important. So we need to have a plan for storing data, and in general for research, the minimum requirements I've got there is 5 years for adults, and for children it's 5 years after the data were last referenced or until the child turns 25, whatever is longer. But in Western Australia, some of our data we have to keep forever, which is different. So I've worked in other jurisdictions, that's not the case. But it's not all of it. When you drill down, it's actually administrative and functional records, so things like ethics approvals, audit data, that kind of thing, but individual participant data can eventually be destroyed. Now, the interesting thing in WA when I arrived here 7 years ago was it said that all your data has to be transferred after that expiry period to the State Records Office for indefinite storage, and that's been full since at least before I got here. So in fact there are some approved sites where data can go, and in the interim, say you've got to look after data for 25 years, you're allowed to store it off-site if you're only accessing it, say, once or twice a year, and it's easy to get to still, so people use all sorts of storage facilities. But you can see why you need to have a budget for all of this, so it's not straightforward, and we can't keep hundreds of boxes under our desk anymore, can't even keep one. So it's really important to have a plan for that. All right, switching topic again. So let's talk about some super basics around databases. So we all know it's for entry, storage and manipulation of data, and we put data into tables, and every row represents a participant usually, or a case, and then every column is a different variable. But what we now have are fabulous things like relational databases, which are great for more complex repeating data. So you link tables using unique identifiers. For example, all the data collected at visit 1, visit 2 and visit 3 is the same, so you just have a table that deals with that and link it with the unique identifier. And then of course we've got web-based databases now, which enable you to have multiple users in people from settings all over the world, allow you to back it up onto the cloud. You can restrict access to certain bits of data to certain people or certain user groups. So there's a lot more complex things we can do now which make managing our data easier and safer. But what some people still don't seem to know is that it's good to put your data into a data capture software program. So you'll notice that not on this list is Excel, and SurveyMonkey is not on this list. So on this list is some really old-fashioned programs that were originally designed for clinical epidemiologists in the field that are free, that you can take anywhere because they take no space on your computer. So that's Epidata and EpiInfo. They're actually quite good. But what we're moving towards now across the board is REDCap, which is also free but has a million fabulous features. Everything I talk about today that is good, you can do in REDCap. So the great thing about REDCap is that it's web-based, but the data is stored locally, so it's safe and secure and it's not up in the cloud somewhere. It's really intuitive and easy to use. There are online tutorials and videos. It can produce all sorts of standard forms and reports. Really importantly, you can put in all the things I'm going to talk about to force you to only put good quality data into each variable, and you can make things compulsory. You can put in skip logic. You can have multiple users. You can only allow access to certain people to certain types of data. You can hide identifiable data. You can send out surveys via text or via email. You can send out automated reminders at specific times. Collects all the data and makes it look lovely. These are data capture software programs, and then normally would transfer them into a data analysis program later on. So those are things like SPSS, Stata and so on. On this list I've also got ones that are specifically used for clinical trials, which are great too. So Medrio and WebSpirit. Some other things like Qualtrics are widely used by some of the universities for survey creation, just like REDCap, but you have to pay for that. And there's a whole lot of others as well. So what I don't want you to use is use Excel, which is what so many people still do. So Excel is not a data capture program. It's not a database program. It's really problematic because you can easily reorder a column and not take all the other columns with you. You could make an error and 5 minutes later think, oh, I think I made an error, and you can only go back arrow about 3 times and then you're stuck. You really need to check everything so carefully, and you can't do any of the things that database programs can do. So you can't make things unique. You can't do the relational tables work. You can't have multiple users. You can't do almost any logic checks, and you can't put in place validation rules to stop you putting in silly things. You can't put in skip logic. You can't do any of that stuff. So it's a really bad program to use, and it makes me cry when I see data in Excel, because you just think, how can you even trust it? SurveyMonkey, everybody uses because, again, it's free, it's easy, etc. And it's fine if you just want to do a quick survey on who's available for morning tea on Thursday next week, but it's not where you put patient data or participant data or health data, because it's actually not you that owns the data. It's up there in the cloud. We don't know exactly where it is. Other people can get to it, and you're very likely to be breaching government policy or institutional policy if you're using it for health data. So just don't do it, or if for some reason you are doing it, just be extremely careful. But you should never have any identifiable or even re-identifiable health data in SurveyMonkey. REDCap, I've already raved about it, and it is now what WA Health is rolling out across the board, and many hospitals and health service providers and universities also are already using it. The WA Health instance is just rolling out now, and I'm going to talk later about resources, but here at CAHS we've been very fortunate to have a close working relationship with Telethon Kids, and we use their instance of REDCap, and they provide support, workshops, the whole shebang. As I said, it's free, it's easy, it's collaborative, it's relational, it's got all the great features that we want. And in the back of your handouts, I've got the whole page on how to access REDCap through health, and I will talk to it briefly as well. Right, so data dictionaries are basically a list of every variable that you're going to collect data on, and we create this before we create our database, so we know exactly what the outcome options are, what the units are, what the variable does, so that someone else could come and join your project or look at your data in 20 years' time and understand what all those really short little variable names actually mean and how to use them. And we normally put in stuff like the codes or categories for categorical variables, and then the ranges for continuous data and things that are allowed and not allowed. And We'll put in codes for missing data and queries, which I'm going to talk to. We'll also put in the names of the tables and how they relate to each other and relationships between your database and other databases. And these again are living documents, because once you start doing your analysis and your cleaning, you'll be creating new variables, so you need to keep adding to it. So obviously every variable has to have a different name, and that sounds silly, but I'll tell you why it might not work to plan in the next couple of slides. And it needs to mean something that gives some information about the variable, what it does, what it's for. You need to know the package you're using and its limitations, so they're all a bit different as to what they'll allow in terms of variable length and uppercase and lowercase and underscores or whatever. So most of them allow underscoring, so you can make the variable name a bit longer. Some of them allow camel casing, so for example the word red cap, where you've got some uppercase and some lowercase, just to make it easier to read the different words. RedCap doesn't allow capitals, so you just need to know this stuff. And likewise, when you import your data into the data analysis package, you need to know what's allowable in that as well. So do your research first. So for example, in Stata you can have quite long variable names, over 20 characters. Epidata is 10 and I think Stata is 8. Most allow the underscore. Stata is case sensitive. RedCap doesn't allow uppercase, and you need to be aware of things that can't be done. I'm just trying to think of some examples. So for example, in Stata, have I got it next? No. So in Stata, if you start a variable with a number, if you've put it into RedCap, for example, and instead of you may have put 1 visit, 2 visit, 3 visit, and then you import it into Stata. Stata will strip the number off, so all your variables will end up having the same name. So more intuitively anyway, it would be visit 1, visit 2, visit 3. Stata will be fine with that. You can't have all numbers. Stata, if you had a variable that was just a number like 100, that variable would be called something like #v if you put it into Stata, so you won't know what it is. So the key message here is just be sure you understand what you can and can't do in whatever package you choose. As I said, the first variable in any database should be a unique identifier, which is usually a consecutive number assigned by the program, and in RedCap that's a compulsory first field in your database, so you can't avoid it, you can't take it out. And you can change the name of it, but that's what it is. And that's so that you can strip out all the identifying information, as I said, and keep it in a separate table. And in Stata you can actually hide those variables so that no one can see them except maybe one person. So as I said, it's generally assigned by you or the package, and it's never the hospital number, and it allows you to link repeating data in tables. This is super boring but also important, because if you select the wrong data type for your variable, then perhaps you won't be able to do calculations on it if you don't choose a numeric format. So most variables in quantitative research will have a numeric or date variable format to allow calculations to be done, even if it's, for example, I've written here categorical data that's only ordinal, for example, mild, moderate and severe. So you would still put that in a logical order and have codes 1, 2, 3, for example, and you can still do things with that. String variables or text variables are the variables where you can put anything you like in, but you can't do any calculations. So pretty much the only thing that should be a string variable is name and address, and everything else will probably cause problems, unless of course you're doing more qualitative question like please give us other comments, and then you distill it down into themes which then become categories later on. With dates, it's very important to choose a date format that is consistent throughout the entire program, or you'll end up having crazy results when you try and calculate age and time variables later on, because it won't work. But always let the package do the work to create those new variables. For example, age should always be calculated from the date of birth and the date of the visit, or whatever the date is that you're interested in. And yeah, don't try and combine text and numbers together, and I'll show you some very super simple examples, but here's one. This is all real data that our hospital biostatistician gave me. So this is where someone did age, not as a calculated variable and not even as a numeric variable, but as a free text variable. Every difference in spelling will come up as a different outcome. So even if there were 20 kids that are all 3 years of age, if somebody wrote 3 years or 3 years or 3 something with a spelling mistake, that will all be counted as a different outcome. And they didn't specify the units, so they've got month and potentially months. So this is completely useless, and if you had 200 or 2,000 people in this study, you'd be pretty stuffed. So yeah, obvious example. Same here with gender. So even case differences will be counted differently. So if you've got uppercase and lowercase, that's a different outcome. So traditionally with male and female, it's 1 and 0, which is very unfair, but that's just the way it is. For most databases, you can do it however you like, as long as you remember what you've done. And I've just referred to codes. So codes are a really good way of helping people enter or record data. And for example, the yes/no is usually yes is 1, no is 0. And you can have a whole stack of questions and just write down 1s and 0s, or you can have it written up in your database so that anything that is ticked as yes goes in as a 1. Now, missing data are really important to handle. So when you've got people churning down a questionnaire going yes, no, or 1, 2, 3, 4, 5, they might miss one, and then you don't know whether it's missed because they weren't sure or missed because it was truly missed. So you need to have a code for missing data, and then when you finish your study, you go searching for all the missing bits of data and try and see if you can fill them in as much as possible. And then when you take them into your analysis package, you have to remember that analysis packages sometimes require you to change that code to the missing value for that package. So traditionally, when you're entering a code for missing data in a data management program like REDCap, you would put a 9, so if, for a 1-digit variable, or 99 for a 2-digit variable. So for example, if it was yes, no, you'd normally have one for unsure, and you'd have one for missing. You'd put in a 1, a 0, and a 9. So those are the options. But then if you import that into Stata, Stata will think that's 9, the number 9. So you actually convert them all to the Stata value, which is a dot. So that's just one example. And likewise, you need a code for queries for every single variable. So particularly for handwritten forms. So if somebody writes something that's illegible or unclear, or it's sort of smeared between two possible options, then you need to be able to go back to the hard copy. So you put in a query code, traditionally 7s, and then you can search on all the 7s, and then you can go back and either recode them to the correct answer or recode it to missing. And the most important thing for the 9s and the 7s is that it can't be an actual potential outcome. So for example here, if you can have weights up to 100 kilos, you wouldn't want to have 99 as your option. You'd want to have more than 2 9s. All right, some general stuff. When you're creating your variables, make sure, as I said, consistent date and time formats all the way through. Always enter the raw data so that you can do calculations later on. So even, for example, in paediatrics, when we're measuring head circumference 3 times, don't you work out the average, let the computer do that, because not only will it be more accurate, less prone to error, but you can also do scatter plots and see if, 2 of them were close together, but one was way off here somewhere, meaning it's pretty unlikely that was a real answer. We sometimes see that in clinic, that people write down the height and the weight the wrong way around, and that gets entered the wrong way around. So you're going to have some huge number instead of some small number. Identify sections with repeating information so that we can think about tables, and also decide on whether your database is going to be a wide database or a long one. So wide meaning you've got 1 record per subject, like I said at the start, and that's very common. But some programs can't handle it riding off into the sunset to the right. You may need to do a long one depending on how big your database is. Ideally, you would do it in a relational database so it's easier. And it's important because sometimes your analysis is going to crash if it's not going to fit that way or that way. So an example here is a wide table where you've just got one record per participant, and this is just an example for HPV vaccine where the kids in Year 8 all get 3 vaccines, and this sort of wide format's good where the time points for all the participants are at similar intervals, but you might go with a long format where each participant is recorded as a separate row depending on what day or what dose, and that might work better. So you just have to think what's going to work better. This one would be better if you were collecting the same variables at each point, potentially. Okay, some little data dictionary simple examples, just so that you know what I'm referring to. So study ID here is our unique identifier, and what we've got down there in the table is essentially that everyone has to have a unique number. There can't be any repeats, and you can enforce that in programs like REDCap. We've provided a range of what the numbers are going to be for whatever reason. It's 1,001 to 2,000, and we know it's a numeric variable, and we know what it's for because there's a little description. And here's one called oral feed, which actually means what was the baby fed, and there are 3 options: breast milk, formula or a mixture, and they're coded 1, 2 and 3, but there are also codes for query and missing. It's numeric, so we can do calculations with it, and we know what it means. Oh, and there's, oh no, that's not a decimal one, this is a decimal one. So this is one where you've got weight at 2 years of age, and importantly the units are in kilograms. So that sort of thing often gets messed up. People don't specify, and then so you've got some people writing in grams or kilos or something else. And there's one decimal place, it's a continuous variable, there's a plausible range provided, which in this case is under 20, which might be a bit mean these days because there's some pretty big people out there in that age group. And you've got suitable codes for query and missing, and I think that's about all you need. But it's very clear, and without that, when you're collecting data, it can be quite problematic. And this is an example of what a data dictionary tool might look like in a program. This one's just in Access, which I wouldn't really recommend anymore, but they all look the same sort of thing, and you just click on the variable, it will give you all that information, or you might be able to print it out as a report. So REDCap does all of that for you as well, and that's something you would keep in your data management plan or file. So I've alluded to relational databases and how you can link tables, repeating information using the unique identifier, which the statisticians or data managers call the primary key. And it basically just makes the data much more easy to manipulate. And I like to think of each table as like an academic paragraph where it's just about one topic, and all the variables in that table must refer to that one topic, and there's no calculated fields, they're all done differently. And if you find that within that table things are starting to repeat, then you need another table linked to it. And this is a non-relational database, the old clunky style, where participants have multiple rows, and you can see the problem with spelling errors and things like the blood pressure should have been done as systolic and diastolic, so you can do calculations with that. And you've got lots of errors with things like medication names, which makes things pop up as different things. And then a lot of people love collecting information, detailed information on drugs, but what on earth are you going to do with that, and how are you going to calculate stuff with it? Because every single one's going to come up as a different outcome. So you need to know what to do about it, whether to break it down into different sections like duration and dates and et cetera, et cetera. So that's a big mess, that one. This is a relational database, and this is an area I used to work in many moons ago, which is to do with ear health. And in the first table, that's the unique identifier table with the identifiable information in it. So first name, last name, address, and hopefully they're the only text fields you've got. And then you'll see that line that says 1 to infinity. So that's a one-to-many relationship with that unique identifier linked by unique identifier. And the next table is about the examination date. So it means you can have multiple examination dates, and under each examination date you can collect this information on left and right ear duct discharge and left and right ear perforation. And then from that there's a one-to-many relationship with swabs. So it's linked on unique ID and exam date, and it's about swab site. And then under that you're collecting information on colonies of Haemophilus influenzae and Strep pneumoniae. And then for each of those there's a one-to-many relationship where they look at isolate count and sensitivities for each of those. So you can see that that looks kind of nicer and less messy, and it's not going for 100 miles over to one side. It's actually a much more complicated thing, but it looks very simple on paper. Right, minimising data errors, super important. So you've got a roughly suitable database structure and you've thought about what program it's going to go into, and now you have to think about making the data as robust as possible. And as I've alluded to, the instrument design stuff I'm not really going to cover today. Go have a read of survey design or watch the recording. But database design, all of these things here, testing it, doing the data entry itself, validating it and cleaning it, are all things you can do to make your data better before you analyse it. So they're all things you must spend time on before you analyse it. The analysis is the fun and easy part. There's all this other stuff that takes time up front, but it's really worth doing. So you can do things in your database setup in a proper program that enforces things like the only values you're allowed to put in. So if someone accidentally slips on an 8 when you can only put 0, 1, 7 or 9, a message will pop up and say it's an invalid option. Or for continuous data or for dates, you can have a reasonable range. That's really great when you've got multiple visits that need to happen in a certain time frame, for example. And always include those codes for missing and query. You can make fields compulsory, you can make fields unique, so you can't have any repeats, and you can also put in skips or branching logic. So for example, are you pregnant? Yes, no. Should not be asked of people who've identified as male. So you should have an automatic skip if you're male down to the next relevant section. And in REDCap, you don't even see the questions that aren't relevant to you, so it makes it even easier to get through the questionnaire. So that's really helpful. I did a questionnaire just yesterday, which came out of one of the universities, and they didn't even say if applicable. They just had all the next questions, and you had to go, well, this doesn't apply to me, I'll just leave it blank. So it's very messy when you then get the data in, or if people tick no, I'm not pregnant, and of course I'm not pregnant, but then what do you do with that? So skips are very important. But then of course you need to test your database. So you might have set it up beautifully, but you might have made a mistake. So you need to try and work through every variable and make sure that nothing unexpected happens and you're getting all those error messages or prompts if you put in something funny. Try and enter a duplicate record where you're not allowed to. Check all your skips are working properly to the next level. Check you can't leave required fields blank. Check all the warnings are popping up. For categorical variables, try and put in something that's not allowed. For continuous variables, try and put something in outside the allowable range, for example. And be aware that depending on the program you're using, you could set up all those beautiful things, for example in Epidata, and as long as you're moving between questions using Enter, Tab or an arrow, they all work, but as soon as you use your mouse, they don't work. So you just need to know stuff like that. I'll come to logic checks further down, but the next thing to think about is how you're going to get your data into the database, and of course a lot of it's done manually, but you can also use scanners, and both of them actually do have an error rate, and you need to think about the cost and accuracy of each. Do you have access to a scanner? Do you have to buy a scanner? Do you have to rent a scanner? Or are you going to pay people to enter the data? And then in terms of accuracy of data entry, you need to train and monitor people and regularly review what they're doing and have a standard operating procedure for what's expected for data entry. Importantly, for big projects, especially where there's a lot of resources involved, investigators often choose to double enter a proportion of data to see what the error rate is between usually different people entering. So if you get the same person to re-enter 10%, you might make the same mistake, so ideally you get someone different. and you might do a comparison between hard copy and electronic copy and get someone to have a look at a proportion. You just have to decide, is the error rate acceptable or not? And of course, increasingly, data entry packages allow more than one person to enter data at one time, which is brilliant. So you can have people sitting all over the country doing multi-centre studies, all entering data at once. Some programs don't allow you to do that, but it's very easy to join files up. And if that's the case, it's usually best to have one person responsible for the merging in case an error is made and you stuff up all the data. So with data cleaning, this is actually time consuming. You have to go through every single variable and look for errors, mistakes, missing values, because you want the shiniest, most perfect data set possible before you analyse it. So it's worth allowing time and getting advice around it if you don't know how to do it. But the most important thing is in bold, never change the original data set. And cleaning is usually done in a command file in the analysis package. So what you would normally do is import the data and then save it as a different name, or import the data and start a command file. And the first thing in the command file is open the database and then save it as something else with a different name. And then off you go, clean variable 1, variable 2, and this is what I did on this day and why, and I fixed this bit here and there. Because one day when you submit to a journal, they'll say, why, you seem to have an error, and you'll never know why you changed something or what went wrong unless you write it all down. The most important thing to do also, as I said, is recode those missing bits of data to the package for the analysis program. It's variable or outcome, whatever it is, like a dot. And if you write everything down, then it's easy to go back and find out where you went wrong. As I said, by the time you finish, you should only have missing data for skips. There shouldn't be any missing data because people left it out. And that's, once you've accounted for all of that, changed it to the program value, you're ready to go. So with logic checks, you need to look for implausible values, inconsistent things, duplicates, and you must have variables for all your eligibility criteria too. That's the first thing. Just make sure everyone in your data set should be in your data set. And then for categorical variables, you're usually just running frequency tables on every variable and seeing what the outcomes are and if there's any stuff in there that shouldn't be there. And for continuous variables, you can either run some kind of summary, which gives you like a mean, a median, a maximum, a minimum, see if there's anything odd, or a dot plot, so they'll scatter all the outcomes and see if there's something really crazy. But as I said, sometimes outliers are real and you just need to go and check. So for example, just this week I came across a 7-year-old who weighs 10 kilograms more than me. So just because something seems implausible doesn't mean it's not impossible. Cleaning dates, always check that the order is logical and within a reasonable time span. So of course your date of birth has to be before your first visit, which has to be before your second visit, and you shouldn't have a second visit if there's no first visit, etc., etc. And make sure you calculate ages and the other things you want to do with time to see if there's something funny going on. Here's an example where the only options for gender were 1 and 2, and there was a 3. So then you would just search on what is the ID if the outcome for gender is 3, and then go sort it out. Here's our variable weight 2, and there's something really wrong because we said it could only be up to 20 and the mean is 26, and there's a huge standard deviation. And what this one actually was, it's all real data, is that there were still some 9s in there for missing that hadn't been recoded. So once they were recoded, the number of observations went down and the mean looked much more simple and sensible. 11, with a minimum and maximum that look right. So very easy to do. Here's one for age. We've got a minimum age of -24, so there's something really wrong there. And you would go back you'd search on that person and then you'd have a look at the date of birth and the date at 2 years and see maybe they've been put round the wrong way or something odd. And here's one with height. So either something really awful happened between age 2 and age 5 for participant 1015 and they shrank, or someone's got them round the wrong way or made an error. So these dot plots or scatter plots can be really useful just to search for mistakes that you don't want in your final data set. Oh, I think we might make it. So resources, we are really lucky here at CAHS and on this campus in general for Telethon Kids that we have loads of resources. But I first want to talk about data managers, because if you have access to a data manager, they are literally worth their weight in gold. So they can help you with everything I talked about today, and large institutions and universities will generally have data managers, but health service providers often don't. But other people can help, like biostatisticians. But they'll help you with design, data dictionaries, creating your database, helping you with the software, all of that stuff, and advice around security and cleaning. In big institutions, the data manager would also be responsible for policy for data and having an inventory of all the data collected at that site as well. And you would give them your data set when you move to another job. Here at CAHS, we have up until now had completely open access to the Telethon Kids instance of REDCap, and because of some changes in licensing conditions, it's now required by REDCap that you can't use the Telethon Kids REDCap unless someone on the project is a Telethon Kids employee. So that's not too sad, because at every single seminar I give, I say collaborate, collaborate, collaborate. It's really important to collaborate, and if you've got someone on your project who is a Telethon Kids person, then you're very, very lucky and you can keep using their instance. But it's also not the end of the world if you haven't, because everyone who works at CAHS can still get one-to-one help on REDCap, and they can also go to the workshops as well. Anything existing at the moment already in Telethon Kids that doesn't have a Telethon Kids person can still stay there for now at least. And the Department of Health instance is now available, and as I said, I've put a whole page in the back of your handout about how to get onto that. And as I mentioned, we have workshops here run by the Telethon Kids biometrics team and through this program here with CAHS. And they're brilliant and they're short and it's so easy to use, and you only need, there's a basics and an intermediate, and you only need a couple of hours, 1.5 for the first one, 2 for the second one, and you'll know everything you need to know to do everything I talked about today. Telethon Kids also provides us with one-on-one support, and there's also stacks of online training videos, and maybe one day, once REDCap's rolled out through health, we'll also have some sort of training support, but it's likely to be online support from the Department of Health. And just to be really clear, if you're not using the Telethon Kids instance of REDCap and you're a CAHS person or a health person using the WA Health one, the only things they can't help you with are the sort of back-end nitty-gritty. So they can't help you with permissions and tricky aspects of the build, because they actually can't go in and look at your project in REDCap. They can only give you general advice. So just keep that in mind. But workshops, everything else is fine. Help with anything to do with data management, you can always email here at CAHS our research support email address, and they'll direct you to the right person. And any biostatistician or data manager can help you with these sorts of issues wherever you may be. And REDCap, as I said, has loads of good stuff online. And you can also do some good clinical practice training around the nitty-gritty of filing and security and naming of data and all of that sort of stuff. So, in summary, this is a huge topic, but do use a well-designed data collection form and a proper data entry package. I will hunt you down if you send us an Excel spreadsheet and try not to use SurveyMonkey. Do have a data dictionary, it'll help you and now and in the future and your team. Try and use a relational database and test every last bit of your database and clean every single variable and keep a record of everything and know about your archiving responsibilities as well. So it is all about being super duper meticulous and getting advice early and putting all that work into the front end of your project so that by the time you actually start collecting data, it's just all happening smoothly and easily with no problems. And remember that the aim of every research project is to collect high quality data that can impact on policy and practice, like I said at the start of the talk. And if we end up with rubbishy data with lots of bits missing and lots of errors, then we really can't take at face value the final results and then impose that on changes in policy or practice. So that's all from me today, and we have time for some questions, either offline, we've got someone looking at the offline discussion, or here. And I just wanted, before I take questions, to alert you to our feedback link, which will be sent to anyone who registered in advance or has given us their email address via email, because we really do want to take on board things that are missing or could be done better, and we'll keep improving what we do. So does anyone have a comment or a question? And I'll do my very best to answer it. We've got a microphone to run around with so people off site can hear. Anything? Up the back there. Thanks, Melissa.
I have a comment on the tools used on the cloud for managing clinical data. Just a comment about these tools are very useful, very nice looking tools, but behind there's the cloud. We all love the cloud, but sometimes it's very tricky in terms of compliance. Just a recommendation to make sure which cloud we were talking about. Sometimes it's outside.
Yeah, well, the cloud, this is it. What is the cloud?
What is the cloud?
Yeah, I think that's why the health department, for example, and other research institutions have turned to REDCap, because although it's a web-based program, the data are stored locally. And that's really important for control of your data, and that's why I mentioned that things like SurveyMonkey are up in this nebulous cloud, but we don't really know exactly where that is or who has access, but other people can, in theory, get into that. So it's why we're moving away from cloud-based, although many institutions back up to the cloud, but I think they're very careful about where it goes. But I can't answer the question of where exactly things are in the cloud, because I don't think we necessarily know.
Thank you. I mean, some tools, commercial tools, they have clouds, but they are sitting outside Australia, and we should be careful about where the data is going, because this is an open gate for compliance problems.
Yeah, and we all keep regularly hearing about really, hopefully, assumed very secure databases like the Singapore health database that got hacked, and the president had all his own health data hacked. So it does happen, and we need to be extremely careful of health data, and we need to be extremely careful about who might be wanting to access that and share it, such as insurance companies or whatever, but it's private information. So we do need to be very careful about de-identifying, and that's again why something like REDCap is so good, because every variable you create, you can say, I'm only going to let this person see this, and all of these sensitive variables are going to be invisible to 99% of my team, and the people in state can only see this bit. So you can be very, very careful about who sees what. Any other comments or questions? Well, if anyone's feeling shy, I'm going to stay around for a little while afterwards if you do think of something on your way out. But thank you all for coming. I know this is an enormous topic, but I hope you got even one or two practical hints about, I guess, common pitfalls that are best avoided if at all possible. Anyway, thank you for coming. It's all right.